Welcome back. Today's lecture, we're going to continue on our look through the nervous system by comparing some of the anatomy we learned in the last lecture with the physiology and the regulatory mechanisms of the brain upon the rest of the body. We're also going to look at some of the divisions, both natural and artificial, that we make when we look at the nervous system and try to classify and put into orderly files the functions and the structure of the brain itself. Let me begin by making a comparison for you between how we get signals out to the body. After all, the brain is a way to signal the rest of the body to do something. It receives information and then it reacts to that information to have something happen, whether it's conscious or not. And we have actually two kinds of signals that go out in the body. If we look at the first slide, the communication systems in the body are generally classified under the nervous system and the endocrine system. Endocrine organs secrete chemical messengers called hormones. They secrete them directly into the bloodstream. Blood circulates in approximately 7 seconds to all the organs of the body, so any of these chemicals are going to be diluted, but that is the general nature of the endocrine system. We'll study that more completely when we get to that topic. But for comparison, let's look here again. The nervous system is electrical. It's electrical mediated by chemistry. In other words, to move current along these so-called wires, which are our nerves, we have charged ions, sodium with a positive charge, we have chloride with a negative charge, potassium, calcium. These ions move in and out of the nerve membrane in various ways so that a charge travels down the length of the wire. It is still electrical, it's just mediated by chemically charged ions. So the nervous system is electrical. The endocrine system is almost entirely chemical. The electrical polarity has very little to do with it. If we compare this, therefore, with the nervous system, the speed of this transmission is very, very fast. It occurs in milliseconds. You can get an impulse from your brain to your toe in fractions of a second. And the duration of the action is very short. Once that electrical event occurs, it is over. It stops. I'll show you how it stops and how we stop it. But this, again, is measured in milliseconds. There's not really much in the way of residual effect. On the other end of that, the endocrine system is a much slower acting system because it has to circulate. And these chemicals some of them have fairly fast activity, like adrenaline, which is one of our stress hormones, versus those like thyroid hormone, which is very slow acting, and it can occur over periods of days, weeks, and months for its activity. So we compare again electrical, fast and over, to chemical, slow and varying in time. The nervous system tends in general to be a converging system, very specific. It reaches one or more effector organs at a time, and only those organs that are actually physically attached to the nerve. The chemical system circulates through the whole body. Now, when certain hormones hit an organ that has no receptors for that organ, it's going to do nothing. For example, if the thyroid hormone, some of it circulates and reaches the cells that line the stomach. There are no receptors for thyroid hormone there. Nothing will happen. But it will go to other organs that, for example, regulate metabolism that do have receptors. So it will find, after a great deal of dilution, the organs that it was intended to signal. That's the big difference in the signaling systems of the nervous and hormone regulation. We have both because we need backup and we need to have a system that has slightly different modes of action for different situations. And some do both. For example, adrenaline, which is our stress hormone, can be elicited from the nervous system directly, but it can also be put out by the adrenal gland. So the same chemical can be put out by both, and it will have its work done in different periods of time. Let's look at the functioning and the physiologic functioning of the nervous system, and look at the next slide, which is a great magnification of an illustration of a neuron. Now, there's some definitions we need to talk about here. We talk about impulses and signals going in two directions. We have mostly what are called motor neurons, which send messages to the body from the brain. Everything below the brain is called below. It's descending. So these messages are called descending impulses. They're also called efferent with an E. Ferre means to carry. These carry away from the brain. So these are efferent impulses, and they are also called motor impulses. And motor impulses only go down nerves that are designed to carry these impulses going away and to a specific effector organ. Every one of these impulses is going down, efferent, away, is going to an effector organ which will do what it is commanded to do by the brain. Sensory function is in the opposite direction. It is never carried by the same nerve as the motor. It comes upward or toward the brain, which is afferent, and it is an ascending function. And in this case, these impulses go back to the brain for sorting and analyzing whatever message or material is there, so that the brain can then integrate it and do something with the motor side, again, in this closed loop. Also in the brain, we mentioned the hypothalamus and the midbrain as integrative function, which analyzes some of this data, puts it all together, and figures out what the brain has to do for it. So those are basically just the two directions we're interested in. And all of this is affected by a neuron. This is a picture of a typical neuron. There are many different kinds. They don't all look like this, but the basic structure is the same. A neuron is a nerve cell. A lot of the things that we're going to talk about in this section have very, very long names. I think the reason is something we call the squid reflex. When a squid is frightened or uncertain, it squirts ink out over the environment and covers and obscures everything. I think you're going to find in medicine, the less we know about a subject, the longer the name is. We cover it with ink. So idiopathic thrombocytopenic purpura is a disease we know very little about. But a gallbladder that's infected, we can say in a very short term. Getting back to the neurons, let's look at this next slide. And we have in the neuron its body, which is the main part of the cell here. And it has appendages here called dendrites, which comes from a word that means tree. The dendrites receive information, perhaps from another neuron, by its attachment, and that information is then sent down the axon, which is the part that goes away. Now, a neuron can have many dendrites and only a solitary axon. It can have all combinations depending on how much information it wants to spread out. So we have issues called divergence and convergence. You can have lots of information coming into one cell, or you can have one cell giving lots of information, or just one impulse to another nerve. Varies in what the job to be done is. The axon is an interesting structure. If you look at this, you have axons that are bare, forget these little sausage-shaped impressions, that just have this limb running down it, and sodium and potassium ions can go across the limb, and the electrical conduction can go down that limb. However, some axons have become what is called myelinated, and they have this kind of insulation. But the whole axon is not necessarily covered. What happens is that certain cells, on the next picture, called neurolemmacytes, or Schwann cells, attach themselves to the fiber of the nerve, like the copper wire, and then begin wrapping themselves around and around and around until it's got lots of layers of this myelin sheath which is primarily fat. It's a very fatty layer, and it's an insulator. And then if we look at what happens here, there are places in between there called the nodes of Ranvier, the doctor who described these, which are bare. And this allows for something called saltatory conduction, which means jumping, from the French sauter. And instead of the impulse having to run all the way down this distance, it is possible for impulses to jump, and this just speeds up the rate of conduction. Some nerves have them, some don't. What is of interest is that the myelinated cells are not complete when a baby is born. I mentioned that last time. And this insulation is something that has to take place over a period of time. Babies, for example, are born with something called the Babinski reflex. If you take a baby's foot and scratch it with a little key or something sharp, the baby's foot will retract, the toes will spread, and it will pull back. That's an uncoordinated response from an unmyelinated fiber. You do that to an adult, and the toes will curl down and withdraw. That's the normal reflex. And when we see this reflex, for example, in an adult, not a baby, then that Babinski reflex signals some damage to the brain's process because it's an abnormal reflex. So we have myelinated fibers, we have unmyelinated fibers, and we have these neurons, which are the nervous tissue that sends the impulse or receives the impulse, depending on where it is in the nervous system. These are the ones that I said you were born with your full complement at birth. You have almost all the neurons you're going to have. There's a second kind of cell that looks something like these, but don't have the same structure completely. These are called neuroglia, meaning nerve glue. I told you that the brain is very jelly-like, and actually without the neuroglia, it would fall apart. The neuroglia are the glue cells. They have all different names. There's a bunch of different types of cells, but basically they're not conducting cells. They look like nerves, but they hold the brain together. They're the supporting structure of the brain. They far actually outnumber the neurons, and they are turning over. You're not born with your whole complement. You're getting new neuroglia all the time. There are glial cells and astrocytes because they look like stars, and they just hold all the neurons in place. Now, one of the things you might ask yourself, which we'll come to when we talk about cancer, cancer forms from stem cells that are trying to come up and replace mature cells and don't make it all the way through differentiation. They are undifferentiated or less differentiated. They fail to differentiate. They're not normal cells that have lost differentiation. So you might ask, as some of my students have, well, then how come we get brain cancer? Why is it that we are able, if we have our full complement of neurons, we don't have new ones coming up? Where do brain cancers come from? It's a very good question. The answer is we don't get brain cancer from neurons. It's very, very rare. The brain cancers occur in the glue cells, in the glial cells, astrocytomas and so on, gliomas. They're the ones where the stem cells are coming up and developing into their abnormal forms, whereas the actual neurons themselves don't form cancers. It is in the last 3 years that we have discovered that you actually do get a few more neurons, but not many. It's a rather rare event, which is why we can't regenerate our brain when there is brain damage. Now, moving on from that area, we need to talk about the functional divisions of the nervous system. And these are complex and mainly for categorization. We'll come back to them. We'll talk about them again. So again, don't try to memorize this aspect of it. The main divisions of the nervous system, first of all, include the central nervous system, which is the brain and the spinal cord. It's literally in the center of the body. The spinal cord is a coaxial cable that carries thousands upon thousands of wires down to the various connections in the body, becoming smaller and smaller and smaller. What's interesting is that these are very, very long cells. When you think of cells and how microscopic they are, if you have a motor neuron in the brain, it sends an axon down to your toe, It's going to leave the brain. That same axon from one cell is going to go all the way down to your spinal cord where it's going to exit, probably in your lower back in this case. And that's going to be there's not going to be intervening nerves attaching each other. It's just going to be the one axon. It's going to signal one more neuron in your spinal cord, and that's going to exit your back and go all the way down your leg to your toe. So just think of how long that is. It's one cell thick. It's this long, long fiber. These are the longest cells in the body. And there are many, many, many of them. So that's our central nervous system. Then we have another division which is called the peripheral nervous system, and these are both the cranial nerves and the spinal nerves. These are the nerves that exit the cord. There's some in the head that go out the bottom of the head, generally to supply the face and the upper neck, and a few that go down to the rest of the body, but they exit in the head at the base of the brain, and the spinal nerves that exit at every level through the rest of the body. And these are the nerves that go to the effector organs, usually motor or other intestinal organs, or to glands. And they are also the sensory nerves that bring the impulse back through long dendrites to the nerve cell that then sends it with an axon to the brain. The peripheral nervous system is also divided into what we call the somatic nervous system, the SNS, which is a voluntary system, conducts impulses to the skeletal muscles. There is then an autonomic nervous system, the ANS, which is involuntary, and it has both motor and sensory impulses, and we are not aware of most of those. We don't know when those are going on except by the effect. Now, the autonomic nervous system is a whole lecture in itself, but briefly, it's divided into two, the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system, which lies right along the spinal cord, its cells are concerned totally with survival. Everything the sympathetic nervous system does has to do with fight, fright, and flight. All the reactions that we have in life and death situations, and which are very primitive, happen in the sympathetic nervous system. The parasympathetic nervous system, named because anatomically it's parallel on either side, above and below the sympathetic system, not because of its function, is rest, recovery, and relaxation. Exactly the opposite. Sympathetic tends to be upregulation, parasympathetic downregulation. We'll get to it in detail. I'll talk to you more about it later, but basically you can always figure out which one is functioning. For example, if you were in a fight and wanted to know which of those was working on your eyes, you would want to have your pupil open widest during stress reaction. You want the most light. At night, in danger, you want to be able to see. Sympathetic nervous system opens the pupil, the parasympathetic nervous shuts it down, takes away the light. So you can figure out almost any organ just by logical reasoning, which is what we encourage our medical students to do instead of instead of memorizing these all as they go along. Now, the nerves are also classified, as I said, as afferent and efferent in general. The afferent nerves carry impulses back toward the central nervous system and are sensory, whether we're aware of them or not. We may feel pain, touch, heat, cold, itching, and so on, or the brain may recognize something going on, like the stretching of an intestine or a drop in blood pressure in the walls of an artery. So it carries both afferent signals that we are conscious of or we may not be. The efferent ones carry them away. They signal also activities and actions that may have nothing to do with anything we're aware of. The impulse for your intestines to squeeze and move food is something you're not aware of unless you have something wrong when you get cramps or pain in that situation of disease or illness. And also, motor impulses may be very much unconscious, yet under control to some extent, like walking. You can think about walking and make it happen, or you can just go ahead and walk. There's kind of a borderline with how much conscious control you have. The Next aspect is the classification of functional categories, the spinal and cranial nerves. This category has to do with a whole series of definitions that I want you to pay no attention to now. I'm going to categorize them for you, tell you how they fit in and why we call them these, but I'm then going to leave it there because we'll come back to them. And when we talk about each cranial nerve, we'll tell you what it does and where it falls into this functional category. The first category is general somatic sensory neuron. General, it's an afferent because it's sensory. It transmits impulses of pain, temperature, touch, sensation, proprioception, position in space, and vibration. And those are all different nerve endings. Each one of those is different. Heat and pain are different. For example, the best way to illustrate that is the cornea of the eye. The cornea does not have any sensors for touch, for light touch, for heat, for cold. It only has sensors for pain. The eye does not want to be touched. It doesn't matter what's touching it, what the temperature is. The surface of the eye wants nothing ever to touch it. It's too dangerous. So if a speck of dust fell out of the air onto your hand, you probably wouldn't even notice. A speck of dust falls on your eye, you know very well from experience how your eye notices, slams the lid shut, blocks out any further dust, and makes you tear until it's flushed away. So it's very, very specific specialization in the kinds of sensation we have. For example, also, if you look at the fibers going to different organs, touch fibers, you take your fingertip, you could have someone touch two pencil points very close together, keep moving them closer together, and they would be almost touching. You had your eyes closed, you could say, I feel two rather than one. You have fine point discrimination in your fingertips. Have the same person do that in your back, and they could take two fingers that far apart, and you'll only feel one finger, because you don't have enough nerve fibers to distinguish two-point discrimination as finely as your fingertips. It's not necessary on your back. It's very necessary on your finger. So, sensation, this is general sensation. It's somatic, comes from the body, and it's ascending, happens in the cranial nerves as well as skeletal nerves. The next section is special somatic sensory neurons, and these are special instead of general. And these are for what we call the special senses. They're different than everything in the body. Vision, hearing, balance, taste. These are the special senses we'll talk about in detail. They're fascinating. They are transmitted from eyes, nose, tongue, and so on to the brain via the cranial nerves. We have general, visceral, as opposed to somatic, sensory neurons. Again, these are coming back from the body toward the brain. They're from the autonomic nervous system. They are telling the brain that you have a load of food in your stomach to make room in the intestine, to pass things on, to squeeze and relax and contract and function. All those general sensory neurons, they're afferent, going back toward the brain, and they tend to be entirely unconscious, unless, again, you have something wrong and they go to extremes, and then you'll feel pain. The intestine's a good example. The intestine only wants to know whether it's overstretched. So when you have too much gas, food, obstruction in your intestine, it will sense the stretching and give you exquisite pain and make you holler until you do something about it. On the other hand, a surgeon in the operating room, if you were awake, could pick up your intestine gently and cut it, you wouldn't feel it. Could burn it with electrical coagulation, you wouldn't feel it. Can crush it, you wouldn't feel it. But if he pulls on it a little bit too much, you'll howl. Again, very specialized, because that's what the intestine has to know about. Next, we have the special visceral sensory neurons, which transmit impulses from what we consider the visceral organs, the kind of internal, unlike the eyeball, and they transmit taste and smell, again, special senses going along the cranial nerves, and we'll look at those in some detail. Finally, we have the general somatic motor neurons, which are efferent neurons. They are going out to skeletal muscles from the brain and cranial nerves and making you move, whether it's wrinkling your eyebrows or moving your fingertips, anything that you can move from your conscious, you can move with these neurons. And then we move on to the special visceral motor neurons, which are efferent, and they transmit along the cranial nerves to the muscles of facial expression, to your larynx for the production of voice and sound, to your pharynx for swallowing, and these are voluntary. Some of these cross a borderline. They sound like they should be voluntary, and maybe they're not. How do you tell? Well, for example, the muscles that hold up your head, which are in your neck, you probably would suspect that they'd be involuntary muscles. You don't ever think about it. You're not conscious of holding your head up. But what is the first thing that happens when you fall asleep sitting up? Your head falls down. So it actually is a conscious, voluntary muscle. It's just one that functions very well without complete conscious control. Now I'd like to move on and talk a little bit more about the cerebrum, some of the higher functions of the brain. We'll take a look at the brain itself, see where the areas are, and then tell you a little bit about what can go wrong and how we found out about this. If you look at the next slide, this is a picture of the brain taken from the right side. It's out of the body, the attachments are all gone, and the brain has been bared except for what is probably the pia mater covering the brain. This is the forehead. The ear would be about here. This is the back of the head, and this is the top. The brain, as you can see, has lots of these gyruses, or gyri, which are heavy, deep convolutions. They also have something called a sulcus, plural is sulci, which is just much deeper. For example, this groove, which is the central sulcus, goes all the way down deep into the brain, separating the frontal lobe from the occipital lobe and so on. And here's the temporal lobe. This is the parietal lobe. We know which areas now cover a lot of the brain functions. We have mapped the brain, and I'm going to tell you about that in a minute. First, I want to tell you why we have mapped the brain. We know, for example, that in front of this sulcus, we have something called the primary motor area. It's called the precentral gyrus because it's in front of the central sulcus. And almost everything we do from the skeletal muscle point of view, fingers, toes, nose, all of those muscles are controlled by the neurons that sit right here. We also have a primary somatosensory motor area, meaning the body sensory area, everything we can feel in the way of touch coming from the rest of the body. This is in the post-central gyrus. And of course, these are not colored this color. The brain tends to be a very pale tan all throughout. We have an area in the back here called visual cortex, or the visual association area, and that's almost like our movie screen projector. That's where all the visual impulses are projected in the brain, divided up into a totally unrecognizable shapes, forms, and colored, and then reintegrated so our mind actually sees what's out there in our world. And in this area of the brain, there's an auditory area in the temporal lobe and other areas of association. You can see speech in this area of the brain. You can have smell in the somatosensory area here. You have a primary auditory area here, very near the ear. And gustatory is taste. And then other areas in the frontal lobe, some of these areas are what we call silent areas. They're integrative functions and so on. They are all coordinated in the center of the brain so that information from these are shared by all the rest of the brain. Now, most of us have heard about epilepsy, a disease which is very common and widespread throughout all populations and comes from various sources and various causes. There is primary epilepsy in which we don't really know why the patient has it. There are other types of epilepsy caused by injuries to the brain, which has left scarring. When you scar, injure, or have a chemical irritant in the brain, what you're going to do is set up activity. If you have, for example, in this area, a irritative focus right at that point in the brain, that's a motor area. That patient, if that starts to trigger by scarring or something else, that area is going to begin to fire because it's electrical chemical charges, and firing certain neurons might light up the neurons next to it and might move down, and you can have the development of a small focus of epilepsy followed by a discharge progressing across the brain. This is called a Jacksonian march, named after a neurosurgeon who described it. And what can happen in a patient with this kind of epilepsy, they may see their thumb start to twitch. Then the area next to it starts to go, and the whole hand is going, pretty soon the arm, and it can generalize until the entire body is firing without any control. That's where you see that patient fall down, violent contractions and shaking of the whole body, frothing at the mouth, sometimes biting through the tongue because the jaw muscles contract, and eventually losing consciousness. The entire brain depolarizes, and the patient loses consciousness. That's called a grand mal seizure. Grand mal is French for big sickness, the worst kind. These patients can have a problem because they can obstruct their airway, they have lost control, they can fall down and hurt themselves very badly, and then they remain unconscious for a period of time. And then after the seizure, they have something called post-ictal depression, post-seizure depression. They have so fired their brain and so stimulated their brain that everything is depressed, and they may have trouble breathing for a while. The paramedics arrive and often have to put an airway in this patient and breathe for them in a very serious type of seizure. Many of these patients are then treated by having medications ordered or prescribed that depress the level of sensitivity of the brain. One of the earliest was phenobarbital, which is just a barbiturate sleeping medication, and it suppresses the level of activity, hoping to reduce the number of seizures that occur. That's a grand mal seizure. There's something called petit mal, small seizures, and these often happen in children, and the symptom is that they are caught kind of losing consciousness, losing time, but no great seizure. They just blink off, and then they're back again sometime later. It's another kind of seizure in another part of the brain. There's something called narcolepsy, in which the patient will be sitting in a chair and fall asleep. And they will stay asleep for some variable period of time, then they wake up again, and they usually don't know what's happened. They kind of know from experience that they've lost time somewhere. A patient with grand mal seizure knows because they're injured. But most of the time, they are not conscious during that. Many seizures are preceded by what is called an aura. Not a new age aura, but just certain feelings. The patient may see colors, may hear sounds, may be aware of some abnormal presence in their environment that's a signal the brain is starting to receive impulses that it shouldn't receive. They're not really coming from the environment. The brain is just firing and interpreting it as coming from the environment. These patients know they better lie down, sit down, stop driving if they're driving, because they're about to have a seizure. They learn this over time. There's another type of seizure that occurs right here in the temporal lobe. It's a very rare kind of seizure. It's called a temporal lobe seizure, sometimes called psychomotor epilepsy. It's really fascinating. And it has to do with the location of the beginning of this seizure, because these patients start off getting impulses that come from here in the temporal lobe. Look what we have. We're very near taste and smell and hearing areas. The patient may be sitting quietly and start doing seeking behavior. Unconscious. They don't know they're doing this. They smell, they sniff, they look, they taste, licking their lips, moving around the room, and this then generalizes, and it can generalize to very violent behavior. Some of these patients will get up, pick up a table, throw it through a window, attack a person nearby, and violently beat them, then lose consciousness and have no idea they did anything like that. It's called psychomotor, because clearly some psychotic behavior was going on, It was motor because it did involve a lot of their organs. Psychomotor epilepsy certainly is very rare, but very interesting for us to study because of the way it evolves and tells us about what's happening in the brain. So whether these seizures are what we call idiopathic, meaning coming from no source, which is a squid reflex, it means we don't know what the source is, or whether they're from previous trauma, where there's scarring in the brain, or other abnormalities, we've always been interested in some way to get rid of this for the patient other than medication. Medication sometimes will do the job and sometimes it won't. There's a wonderful history of this area, and it revolves around a doctor who was a neurosurgeon at McGill University in Canada named Wilder Penfield. Dr. Penfield was very interested in seizure and disorders and with the corrective surgery. He thought if we could get rid of the irritated focus that started the seizure, maybe you could cure the patient. Leave his little scar tissue behind, get rid of the scar tissue that was there. So he wanted to operate on these patients and find their focus for the seizure. What he did was he needed to do these patients while they were wide awake. Now, you can do this relatively easily with some skill. You merely inject the skin of the scalp with xylocaine, a local anesthetic. You make your incision. You can anesthetize the bone and its coverings and make your hole in the bone. And then you can go through the dura and expose the brain. You can operate on the brain without hurting it. It's kind of counterintuitive. The brain has no pain fibers. This doesn't really make a lot of sense, but what the brain is an interpreter of pain. When you burn your finger, your pain is not in your finger, your pain is in your brain. It's the perception of pain. And the impulse is going up into your brain says, ow, that hurts. When you give a patient morphine, all you do is change the perception of the pain. Most morphine patients will tell you, a post-operative patient who you've given a pretty good dose to will be wide awake and say, yeah, I've got that pain, so what? It doesn't bother them. The perception, the reception of the pain is changed. On the other hand, if I put local anesthetic in, I've blocked the nerve impulse. It's not getting up the nerve. So the brain doesn't even know there's pain. I can then mangle that finger, which can be dangerous. For example, when you've had your teeth worked on and your whole mouth is numb, you're always very careful not to chew up your tongue or your cheek because your brain's never going to know what's happening. So that's what allows us to operate. I've digressed a little bit, but that's what allows us to operate on the brain. You can then say, well, why do I get headaches? Why do brain tumors hurt people? The reason they do is they're stretching the vessels. It's the vessels in the brain that hurt. When you stretch a vessel or inflame it, it's the blood vessel that's hurting you. And that's why some headaches are throbbing. It's the stretching with your heartbeat that makes that pain in your head, not in your brain. So Dr. Penfield had the ideal situation. He could operate on the brain with the patient wide awake and just sedated. And he could go into the brain substance, and what he wanted to do was take a very fine electrical stimulation until he got to the point where he found what was wrong with the patient. So if this patient had a seizure disease, or diathesis we call it, where the hand started, he'd look for the area and he'd stimulate until he got the hand to do it, and then he might find the scar tissue and cut it out. But he was no fool. He knew this was a wonderful opportunity to learn something without doing anything bad to the patient, because he had to go through the brain and stimulate different places and find out what was, when he was getting near the diseased area. So he wasn't just going to do this and get the job done. He was going to make sure somebody was taking notes. So he'd touch a piece of brain, let's say up here on this picture, and the patient's face might start to twitch. So he'd write down that the facial muscles were right there, the part that controlled it. He would touch a piece right here, and the patient would say, ow, I've got pain in my left thigh on the inside. And he would write down left side, inside of the thigh, right here. And over the years, doing thousands of patients, he mapped the brain for us. He found where each of these places were. Then he would go and do his surgery. And Dr. Penfield developed a little man called the homunculus, a little human being. And it's fascinating what he found out. If we look at the next slide, we have two sections of the right half of the brain facing us. It is the horizontal section I told you about. I'm sorry, the frontal section going straight through the head, removing this portion of the brain. And this part here is called the somatosensory area. So it is the area exposed by cutting through this part of the brain, this gyrus. This side is the motor area on the same side of the brain. So it's the part that's cut through here, just in front of the central gyrus. And he drew this little picture. This is our little homunculus, our little man. Notice, number one, that the body doesn't lie across the top of the brain in the normal anatomic order. For example, the head in both the motor and sensory area is not attached up here to the neck. It's down beyond the area for the thumb. This probably happened during evolution when the brain was making its convolutions, when the brain was expanding, folding itself and refolding itself to try to have room in the cavity over hundreds of thousands and millions of years, and these areas got separated. What's interesting is both sides of this brain are very similar. The head's in roughly the same area. The lower jaw here is disconnected in the sensory area. The thumb, look at the enormous representation of the thumb relative to the other fingers, but look how big the hand is relative to the foot. And look at the back. Remember when I said that if you put 2 points on the back, you can have your fingers very far apart because the brain's representation is very small. It can't tell the difference. Now you can see why I could do that same thing to the thumb, and my fine point discrimination is very fine compared to the back. It goes down into the sulcus. This is kind of interesting. Remember, we saw the ventricles. Here's the ventricle in the brain. So that sulcus only goes so far, but the body's using every inch, every millimeter of the brain to lay out neurons so that if Dr. Penfield touched here, this toe would probably wiggle. And if he touched it on this side of the sulcus, the patient would say, ouch, my toe hurts. The representation is proportional to the function, both sensory and motor. Look, for example, at the size of the lips on this side. And our lips are extremely sensitive to touch and feel. Look at the mouth here. He's representing really here vocalization, salivation, mastication here is chewing, and so forth, swallowing, this huge area of the brain represented. And the reason it's laid out along the surface is that that's where the neurons are. That's where the motor neuron, the cell body is. The axons, which travel down to the body, are deeper. So this is the gray matter up here on top in the cerebral cortex. The gray matter is, the white matter is down here, bringing these impulses to the rest of the body. Now, people are doing other scans today called PET scans, positron emitting scans, combined with MRI, and they're doing functional scans. We have kinds of scans that are anatomic, like an X-ray, like a CAT scan, which CAT scan just shows density. MRI shows magnetic changes, magnetic resonance imaging, and PET scans are functional. They're showing what the cells are doing. People are doing studies today on musicians, on athletes, on people sitting around reading and thinking, and they're able to see now what portions of the brain are lighting up, where there's a lot of functional activity, which can show up as color on these scans, and when there's not a lot of functional activity. So what happens now is we can take Dr. Penfield's work, which was done in the last century, now more than 50 or 60 years ago, combine that with the maps we're getting from PET scans and get very precise and sometimes very alarming and surprising definitions of where certain functions are going on in the brain. We're going to look at that as we get through our next lectures. We're going to take each of the areas of the brain, look at their function, and see how they work, how they're associated, and how they make our body do what it wants to do and do what it has to do to survive.